Hello everybody, my name is Hui-Nam Pak, Yonsei University, Severance Cardiovascular Hospital, Seoul in South Korea. I'm glad to have you, all of you, to this educational video clip. I would like to talk about the procedure itself slowly, and I would like to say the hidden secret tips one by one. So I hope everybody will enjoy this session. The first question is, what is the mechanism of atrial fibrillation? Atrial fibrillation is a very complicated mechanism, but as an electrophysiologist, if you don't understand the mechanism of atrial fibrillation in detail, it is very hard to apply your technique to very diverse and complicated patients. So first of all, you need to keep in mind that there's two different mechanisms of atrial fibrillation. First one is trigger mechanism, and second one is maintenance mechanism. Even though some people has frequent atrial premature beat, if it doesn't sustain as a fibrillation, the patient never have atrial fibrillation, only skipping beats and APC. And second one is, even if the patient has some substrate, if there is no APC, there is no atrial fibrillation. So you need to divide the mechanism of atrial fibrillation. Number one, trigger mechanism. Number two, maintenance mechanism. And traditionally, basic scientists, electrophysiologists, classify the maintenance mechanism of atrial fibrillation as two classes. One of them is the focal source mechanism. So there is some fibrillating focus or rotor maintains atrial fibrillation. And another part of basic electrophysiologists say that there is a multiple wavelet hypothesis. There is no focal source, but if there is significant substrate and the critical mass, so-called, in other words, if the size of atrium is big, atrial fibrillation can maintain with continuous wave break. So the maintenance mechanism of atrial fibrillation is a focal source and the substrate, that is multiple wavelet hypothesis. So in Yonsei University, the Severance Hospital strategy for the paroxysmal atrial fibrillation is that there's no doubt about the pulmonary vein isolation is very, very important. Most important, the parasympathetic ganglia innervate to the heart is on the third fat pad. It locates at the beside of SVC junction and the aorta, this area. So we ablate from SVC to fossa ovale by linear ablation in right side. Also, there is another fat pad at the base of, this is IVC, coronary sinus is here, and this is middle cardiac vein. There is another big parasympathetic fat pad. So we try to ablate this area, so that's why that is another rationale to ablate the cable tricuspid isthmus ablation in our lab. So for the patient with paroxysmal atrial fibrillation, our basic ablation lesion set is PV isolation and SP septal line and cable tricuspid isthmus ablation. Of course, there is some strategy, but my institution continue the same strategy for paroxysmal AF. For the persistent AF patients, there is so many diverse trial to improve the outcome of rhythm outcome of persistent atrial fibrillation. But nowadays, there is no consensus for the circumferential PV isolation is important, but in additional linear ablation, cafe ablation, rotor ablation, any other kind of ablation is just a 2B indication in the guidelines. So last 10 years, we try to make a linear ablation in so many patients. For example, posterior box isolation and anterior linear ablation. But after the randomized clinical trials and the retrospective studies, the linear ablation did not improve the rhythm outcome in patients with persistent AF. That is our laboratory data. Of course, there is some subpopulation who improved the outcome of catheter ablation after linear ablations. However, in general, the additional linear ablation was not beneficial for the patient with persistent AF. The only thing we found the beneficial for the patient with persistent AF is the after PV isolation, if there is an extra PV trigger, it is quite helpful. It can reduce their recurrence rate. So after, regardless of paroxysmal persistent atrial fibrillation, we try to induce atrial fibrillation again by isoproterenal provocation, and then we give a cardioversion. If there is a trigger or frequent APC, we try to ablate them all. Groin complication is not fatal complication, but it is very annoying and common complication. So try to reduce their groin complication. We are using the vascular sonogram when you do femoral vein puncture, and you can differentiate which one is femoral artery and which one is femoral vein by compressing your groin, the patient's groin area with probe. If it is compressible, that is definitely femoral vein. So try to inject local anesthesia and insert the broken puncture needle to that directing to the femoral vein. It's quite easy. So we are using 2 venous puncture and use 14 French tripod sheaths, and the other puncture for the transseptal long sheaths. So just 2 puncture is our standard ablation access. We are using 14 French tripod sheaths. You can put 3 mapping catheters through this sheath. So that's why that we are using just 2 puncture. But to make sure this sheath is very tough, especially dilated, very tough. So make an incision and push the sheath gently and slowly. And when you push the sheath, you can try to move a guide wire freely and check it repeatedly. If guide wire is bent, you can move this guide wire freely. That means your sheath may damp to the venous wall. If you push more, probably you will make a disaster. The AF catheter ablation, probably the fellow's most difficult first hurdle might be how to put this duodecapolar catheter inside of coronary sinus. This catheter is 20 pole and deflectable. So if you rotate the handle clockwise, the catheter make a curve. This catheter is very useful to map the coronary sinus, also the right atrial free wall altogether. Also, you can deliver cardioversion energy with this electrode. But the difficult part is how to put this tip of the catheter inside the coronary sinus. So I would like to give you my tip. First of all, you can move catheter to the right atrium first, and then try to make a curve. And make a full curve, and push in. So make this position, like this position. But depending on the catheter tip position, sometimes you can luckily engage coronary sinus, but sometimes not. So make a figure 9 position in LAO view first. That is first tip. And second step is make RAO view. And then catheter might stay like this. If in RAO view catheter position is like this, if you push catheter, you cannot engage the CS. If this position, your catheter will move to the right ventricle. So if your catheter is here like this, how can you move to anteriorly? And in this time, if you rotate your catheter counterclockwise gently, your tip of catheter move to CS. If it is in this position, opposite direction, counterclockwise torque, and you can engage CS. So you can estimate the location of coronary sinus in the RAO view, and then back to the LAO view, and gently push the catheter slowly. And if you feel your catheter is engaged the proximal coronary sinus, open the curve slightly and push more. And probably you can get the CS very safely and easily. Okay, that is the duodeca catheter position maneuvering tips. You can push the duodecapolar catheter into the IVC. You can just follow the previous catheter and guide wire. And in LAO view, direct your catheter tip the right atrial free wall side and make a full deflect down and counterclockwise torque, make a figure 9 position in LAO view like this. And luckily our catheter already put inside of the coronary sinus, and gently push little by little, and you can check here the catheter position proper or not in RAO view, and you can imagine the coronary sinus location by the in the RAO view. You can make sure that the CS position by the distance between vertebral body anterior aspect to the coronary sinus ostial area. The next step of EP procedure, AF ablation procedure, is transseptal puncture. I think the most stressful and the nervous procedure for the beginner might be the transseptal puncture, because it has a risk of cardiac tamponade and serious complications. But if you keep the rule, it might be very, very safe procedures and easy procedure. You can use any kind of transseptal sheaths, but I prefer to use Schwartz left 1 sheath, SL1 sheath usually. And there's 2 parts. Tip of the sheath is generated by the rubber. When you enter this sheath inside the skin, if there is some resistance, don't hesitate, pull out and use mosquito and dissect the soft tissue. Then you can easily push inside the vein. Okay, and when you put your sheath tip left innominate vein, then you need to remove guide wire and exchange with this the broken broad needle. Okay, broken broad needle shaping is actually the key process of transseptal puncture. You need to shape this broken broad needle depending on your anatomy. When you put the CS catheter in the standard catheter position, I think you can guess where's the septum and how's the angle of septum. So when you make a curve of this broken broad needle, it depends on the right atrial size. If right atrium is very huge, you can make a big curve like this. If it is small, very small right atrium, you can make a small curve like this. And if septum is straight up, you should make a right angle. If septum is very slanted, like old people, you can straight up the needle. Okay, so make sure the curvature of broken broad needle is dependent on the right atrial size and the septal angle. The SL1 sheath still in the right side innominate vein, and then you need to push your broken broad needle inside. When you push the broken broad needle inside the SL1 sheath, please keep the stylet. Don't remove this stylet. Okay, this stylet put inside of the broken broad needle, because the needle tip is very sharp, and after shaping, sometimes the tip of broken broad needle scrape out the plastic part of dilator. So it is safe to put the stylet inside, then push you need to remain the 2 finger breaths between the dilator tip and the needle. And also it is important to keep the angle of side arm, and there is the French marker, round ring marker, and the needle should be parallel altogether. This one should be parallel. Innominate vein to down, 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 down in LAO 35 degree. And there's 2 jump, because there's aorta contact area. There's 1 jump, and there's fossa ovalis and 2nd jump. If you can see your dilate tip located in the fossa ovale, then you move to fluoroscopy to RAO 35 degree. Okay, RAO 35 degree, your sheath probably direct like this. And you can move down, upper, anterior, posterior. If you want to move the dilate tip anteriorly, counterclockwise torque. Counterclockwise torque make anterior direct, and the clockwise torque make posterior direct, right? But make sure the proper location of your dilator is between hip-bundle catheter. Hip-bundle catheter location matched to their aortic cusp, and their posterior cardiac silhouette, posterior 1/3. Between hip-bundle and posterior cardiac border and posterior 1/3 position might be the proper position for transseptal puncture. So in RAO 45 degree, you can adjust your catheter position and then come back to LAO view and watching the location of tip of dilator and gently pushing the whole system, and probably tip of the dilator make a tent of the septum, and gently push the needle inside and push inside the dilator, then sheath in, and you can remove everything. After takeout, after the generated successful transseptal puncture, please remove 5 cc of blood outside and then flush it, because your guide wire put inside the body quite several minutes, and potentially there's some aggregated clots. So please remove 5 cc of blood, take away, and then flush this sheath and start your procedure. This guide wire is put inside of SBC, and we put the transseptal sheath put into the innominate vein along this guide wire, and make a small incision on the skin. And because the tip of transseptal sheath made by rubber, if you push it more vigorously, you can damage the tip of this sheath tip. Then it is hard to pass the transseptum. So if you feel some resistance on the skin, you can dilate it by mosquito catheter. And now transseptal sheath is already inside the innominate vein, and remove the guide wire. The location of innominate vein is just 1 vertebral body length higher than trachea bifurcation, and you remove the guide wire and then flushing and put the transseptal needle, broken bone needle, inside the dilator. And it is very difficult. It is very important to shaping the broken bone needle depending on the right atrial size and the septal angle. So we put the long needle inside the dilator, and the 2-finger breaths should be separate from the tip of the dilator and the broken bone needle marker, and the side arm marker and broken bone needle marker should be parallel altogether. And in the LAO view, LAO 35 degree view, we pull back the catheter, and in this position you should make sure you can see the radial opaque marker at the tip of the sheath in between the dilator. It should you should maintain this marker linear position. If you see the ring shape, your broken bone needle is tilted to anteriorly, posteriorly. So you need to keep this marker in the linear position, which means you are maintaining the maximum curvature of a broken bone needle. Okay, and here you need to rotate your fluoroscopy to RAO 45 degree, and you can estimate where is the posterior cardiac border and the hip-bundle location. So the proper position is posterior 1/3 in between hip-bundle and the posterior cardiac silhouette. Then, if you believe your needle position is correct, move back to LAO 35 degree and the puncture. So in this patient, probably the interatrial septum is very thick. It's very hard to push the dilator inside the LA. So if you think that you puncture the transseptum, interatrial septum, but there is no draw of blood to the syringe, do not push your dilator at all. It is very, very important. If there is no blood in the syringe, when you draw back the syringe, your needle tip is not the proper position. So never try to push your dilator inside. Yeah, still there is no blood. Yeah, I push it hardly, but still there is no blood withdrawal. So in this time, you can choose plan B. Number one is you can try to use stylet already inside of a needle. Yeah, when I put the stylet, you saw the tip of needle popped inside of LA successfully, and you see the blood withdraw. Then you can safely push your dilated inside and successfully pass to the interatrial septum. And second choice, you can use the RF needle. And third one, you can use a low energy Bobby power on the tip of the broken broad needle. I put the ICE catheter inside of left atrium through the SL1 sheath. This is home view and aorta. And then right side of aorta, you can see the appendage. So if you rotate the ICE catheter gently to clockwise, you see the left atrial appendage nicely, and check the appendage flow velocity. And if it is over 5 meters per second, probably there's no appendage thrombus. But usually appendage thrombus located at the tip of the appendage. You can move back and forth your catheter gently and try to find out any kind of risky thrombus inside the appendage. Even though we are using 3D mapping system, I always check the contrast media injection and make a good LA angio view in AP view and RAO 35-degree view, and put this angiogram beside of 3D NAVX image, and I checked my ablation catheter position from time to time through comparing this angiogram and the real-time ablation catheter fluoroscopic imaging. So for the angiogram, we usually pace right ventricle rapidly, and by reducing the diastolic filling time, you can make a beautiful angiogram. During angiogram, you start your pigtail catheter inside the left upper pulmonary vein and rotate your sheath, and the pigtail tip move to the right side upper pulmonary vein. Okay. Start pacing, dye injection, clockwise torque, and you can make a angiogram. And move to the RAO view, one more shot. When you put your pigtail catheter on the right superior pulmonary vein. Pacing, and yeah, so you can imagine where is the location of right inferior pulmonary vein ostium. Now I would like how to handle the catheter movement. Rule of thumb is when you put your catheter inside the body, rule of thumb is if the tip of the catheter doesn't move, do not push the catheter. That is very, very important for the safety of the patient. And second rule is you need to move catheter very, very slowly. Generally, I would recommend to my fellows move catheter 1 millimeter and wait 3 beat cardiac beats. Ablation procedure is mainly done by left hand, not right hand. Right hand is very crude movement, deflect down, curve up, and clockwise counter rotation. But if you move to the target area, you can use right hand. You manipulate catheter for the proper contact and precise mapping and ablation. The left hand is more important. So watch my hand. Use third and fourth finger grab around the sheath, and the thumb finger and index finger grab the catheter, and clockwise and counterclockwise torque was done by like this. So left hand is more. Because the curvature to left upper pulmonary vein and the right side upper pulmonary vein is easy because it is natural curve. So if you put just push the grid catheter, push. If it is not the appendage side, it naturally going to the left upper pulmonary vein. But make sure if the catheter tip moves directly to appendage, the tip of catheter did not move outside of the cardiac silhouette and on the fluoroscopy. So always you try to gently clockwise torque and push the catheter, and you can put your catheter inside the left side pulmonary vein. Another tip is you need to watching the electrogram signal. Appendage signal is broader and big amplitude. If you see the broader and the big amplitude, you should not push catheter. It is appendage, not the left upper pulmonary vein. And if you move to the right upper pulmonary vein, just clockwise torque whole system, and your catheter will move to the right side pulmonary. So if you curve down clockwise torque, make a posterior inferior drag, and just push the catheter. If you are lucky, you can put your catheter inside the left inferior pulmonary vein. But sometimes, if pulmonary vein is flat, very flat and the narrow diameter, it is hard to push the grid catheter inside. In that case, make a big curve like this, and clockwise torque directed posterior, and push. And if the tip of your grid catheter is just inside of left inferior pulmonary vein ostium, you can just keep the same position of sheath and push the catheter slowly and open the curve. Push catheter and open the curve, and you can get the left inferior pulmonary vein. Okay, from right superior pulmonary vein to right inferior pulmonary vein, imagine where is the patient right inferior pulmonary vein located. It is more posteriorly directed. So if you want to move your catheter posterior direction and from right superior pulmonary vein to inferior vein, deflect down and counterclockwise torque and direct posteriorly, and then you move to your fluoroscopy to the RAO view, and you can see where is your catheter position, tip directed right inferior pulmonary vein. Sometimes it is very difficult, especially in small left atrial size. Then you should curve down, make a sharp curve, even this kind of sharp curve, and direct the right position to right inferior pulmonary vein also, and open the curve. And then catheter is moved inside the right side pulmonary vein with this position. It's not easy to put the inferior pulmonary vein engagement. You need to watch your angiogram you took at the beginning of procedure and imagine where is the patient's inferior pulmonary vein located, and probably you will succeed. So when we start left atrial geometry with HD grid catheter or the ring catheter, please make sure your catheter movement should be very, very slow. Whatever the rhythm status, it is the sinus rhythm or the atrial fibrillation, I open the recording the electron voltage map together, because during atrial fibrillation you can get the fractionated map with this automap module, and the fractionation map could provide you with some location of a complex electrogram. So I usually start map with left atrium proper, and the posterior wall, roof, posterior wall, and anterior wall, and the septal side. Then I start to map the each pulmonary vein separately. Right side, right inferior pulmonary vein, left upper pulmonary vein, left inferior pulmonary vein. Then move to the left atrial appendage, and of course the mapping of the left lateral isthmus is also important. So at the time after finishing the acquiring the electrogram and geometry positioning with multi-electrode catheter. Then I exchange the catheter to the ablation catheter and check the location of the secondary branches of pulmonary vein to generate a better CT merging. So you can see this kind of small white spheres, which means the fractionated potential locations. So even during the atrial fibrillation status, it is quite easy to find out where the fractionated potential exists. And then after getting the general geometry with ring catheter or HD grid catheter, then I exchange to the ablation catheter to check out their secondary branch. Yeah. After getting the geometry, 3D geometry of the patients, you need to give enough time to the FCE to make a fusion process and trimming of the left atrial geometry. Don't be in rush. If the trimming and the CT merge is incorrect, you will spend more time to get the proper result outcome. So give FC enough time to make a very sophisticated and detailed. I usually, during FC generating the CT merge, I do the right side ablation after take out the transseptal sheath right atrium, and I generate a SVC septal linear ablation. It is ablation from SVC tip to upper posterior limbus of fossa valley. And I usually deliver 20 to 30 seconds, 25 watt, 20 seconds in each point, and then move to the cable tricuspid isthmus, try to make a generator CTI block. So generally, after these two linear ablation, the FC finish up the CT merge process. Then I enter the left atrium again and start pulmonary vein isolation procedure. Next step is cable tricuspid isthmus ablation. Probably some of our audience doesn't agree why we need right atrial ablation for the patient with atrial fibrillation, but I just talking about the general practice, our protocol in my laboratory. So we will discuss about this kind of right side ablation at the discussion time. So after giving the CTI ablation, still the rhythm is atrial fibrillation status. So after finishing the PV isolation, make a sinus rhythm, then we will recheck the bidirectional block at the end of the procedure. Okay, this is SV septal line and CTI ablation lines. And still the FC is emerging the 3D geometry with CT scan. Before starting the PV isolation procedure, I would like to recommend to exchange your catheter with the ring catheter or the H-degree catheter and check the location of a PB antrum one by one. Because even though the magnetic sensor keep the proper location and proper position of geometry, sometimes patient move or sometimes by deep respiration tilt your geometry. So to make sure the proper geometry, I would like to strongly recommend to check the antrum, PB antrum position one by one, and then you can start safe RF ablation and smooth RF ablation. Your sheath is inside of the left atrium, and the catheter is here. To make a better contact and good contact force, it is better to maintain the short distance between the tip of the sheath and catheter tip. If it is like this, catheter is protruded outside of the sheath, the contact force is reduced. So if you can, it's better to short distance between sheath tip and catheter tip, and try to ablate anterior and posterior like this. If you want to move down to left side pulmonary vein, upper pulmonary vein to the lower pulmonary vein, if you pull back your sheath, catheter tip is downward. So in this time, you need to push catheter, pull back the sheath, make a better contact to left inferior pulmonary vein. And for the anterior ridge of left side inferior pulmonary vein, sometimes it is better to make a sharp curve and for the good contact. Okay? And when you want to move to the anterior side ablation, imagine this is the anterior part of a pulmonary vein. This is posterior part of pulmonary vein. If you make a counterclockwise torque, make contact, you can make a contact to anterior pulmonary vein, clockwise torque, and posterior work contact. Okay? So imagine how to make a good contact by clockwise torque and counterclockwise torque. So for the left side pulmonary vein, counterclockwise torque make a better contact to anterior ridge, clockwise torque make a posterior contact ridge. Okay, now you can imagine this is the anterior side of a right side pulmonary vein, and this is posterior side of a right side pulmonary vein. So you can imagine you're watching the right side pulmonary vein inside. So right side pulmonary vein, if you try to make a clockwise torque, make a good contact to anterior wall, counterclockwise torque, make a contact to posterior wall. But when you ablate the posterior aspects of a right side pulmonary vein, sometimes it is make a good catheter stability because catheter is almost perpendicular to the wall. So, and another difficult part is if you try to ablate the roof of a pulmonary vein, sheath is already inside PV. So in this time, it is very difficult to make a proper ablation in the upper pulmonary vein and left side upper pulmonary vein and right side upper pulmonary vein. In this time, you can push catheter inside and deflect down a little bit and just put the catheter inside the PV and pull back sheath and make a torque and generate this type of second curve like this. Okay, for the right side pulmonary vein upper roof, also opposite direction, you can make contact like this. So generating second curve is useful to make a roof of both pulmonary vein. Okay, now let's start the PV isolation. I usually start from the left side upper pulmonary vein and the anterior ridge because this location is the most important part of PV isolation and the high recurrence in this area. As I told you during the explanation, the teaching video, the distance between the sheath tip and ablation tip is important. If it is too far away, the contact force is reduced. If it is too short, sometimes you make too high temperature and risk of complication. So adjust the contact force is very important.
even though the tacticat catheter or the smart touch catheter can monitor the contact force, but I prefer to use this flexibility catheter, because flexibility catheter generate a bigger lesion, and the temperature thermal sensor is located at the tip of the catheter. So even though we cannot believe the tip temperature during using the irrigated tip ablation catheter, but some degree the temperature reflects the tip temperature when I use the flexibility catheter. So I prefer to, it is my favorite catheter to ablate it. And nowadays I'm using the 50 to 60 watt hyper short duration ablation. And with the 50 watt ablation, in the anterior aspects of pulmonary vein, I usually maintain 10 to 15 seconds, but it depends on the patient body size and gender. If the old lady with small size heart, I reduce the duration of ablation less than 5 seconds sometimes. So far, I use the hyper short duration ablation more than 300 cases, but so far, in my experience, is pretty good and safe. But the posterior aspects, you have to be very, very careful.
Even though the hyper short duration ablation make a surface burn, not a deep burn, and broader lesion generation, but the left side the posterior wall is still very dangerous area, because there are many critical structures contact with LA posterior wall, especially esophagus, aorta, and vertebra. So when I try to ablate the posterior wall, I usually deliver less than 50 watt and left less than 10 seconds. And if patient complain pain, I stop burning and move to another position. And I think the monitoring of esophageal temperature is mandatory. If you do not monitor esophageal temperature, do not use hyper on the posterior wall. And also, even though you monitor the esophageal temperature, if the temperature tip is there is a distance discrepancy between your ablation catheter and the temperature tip, this temperature does not provide you the proper information. So your catheter tip is away from the esophageal temperature probe. You need to ask your nurses and technicians move to this esophageal temperature close to the ablation the point. And I usually use cutoff value of esophageal temperature is 38.4 degrees Celsius. If it is going up, do not ablate. Just move another point. So I recommend to you ablate the posterior wall stochastically, not the linear continuous ablation, to give a chance to cooling down the esophageal temperature. So move this point and other point, comes and goes, and finish up the ablation. And also, if there is a very small potential is recorded on the tip of ablation catheter, move the catheter rapidly to another point.
So in this point, the temperature is over 39. So I move on to the other point. So like a frog jump, I ablate the posterior aspects of the left side antrum, from here to away here, because we need to give a chance to cooling down of increase the esophageal temperature. So during the cooling period, the esophageal temperature, I generally added the linear ablation along the posterior aspects of appendage. As I told you, there is folded area between left side pulmonary vein and appendage, and in that area, the muscle thickness quite thick, like a funnel. So in the folded area, all those folded areas filled by muscular structures. So I added the linear ablation and the posterior aspects of appendage. Another reason for the posterior appendage, LA appendage linear ablation is to targeting the ligament muscle. Ligament muscle branches many the nerve fibers to not only pulmonary vein aspect, but also appendage aspects. So that's why I give the same high power ablation short duration along the appendage posterior aspects. But please make sure if push your ablation catheter a little more, freeward side of a left atrial appendage has very thin musculature with a lot of triarticulation. So don't ablate inside of appendage, just appendage ostium, the posterior aspects is my target. Let's move back to the posterior aspect of atrium, left side antrum again, and ablate with monitoring the aspirator temperature. The roof aspects of pulmonary vein is hard to approach because sheath is already inside the pulmonary vein with natural curve. In that case, I already told you make a second curve ablation. So watch the fluoroscopic image. Okay, push the ablation catheter inside of pulmonary vein and twist the sheath, make a second curve. And then your ablation target is matched to the antral area. If you make a second curve, don't try to change the catheter position and make a torque on the catheter. Just push and torque with sheath, not catheter alone. So I think this area include the septal pulmonary bundle. It is a very thick and important bundle. Sometimes epicardial connection make the PV isolation procedure very difficult. So it is important to give enough energy. Sometimes patients feel pain in this area and the vagal response. And finish up the left side of PV antral ablation. Then I generally give the cranial line with 30 watt, very short duration. If there is no potential, I move, just checking the PV potential. You should watching the ablation signal continuously. So if there is no signal or very small potential, then you can move faster. But if it is huge signal, you can come back and give more ablation energy.
When you ablate right posterior PV antrum, you can imagine the catheter contact direction because transseptal side and your target side, right posterior antrum, is almost perpendicular direction. So it is very difficult to make a good contact. If you push a little bit, the contact pressure is too high. If you pull back your catheter a little bit, the contact became very poor. So it is very important to push and pull back your catheter continuously and make a better contact. And also, this area contact with posterior wall, posterior mediastinum, patient complain pain quite often. So please give her enough time to ablate the right side, posterior side antrum ablation.
Okay. So some patient has a very folded structure in this area, which means the vertebra, aorta, or some other structure pushing the posterior wall. In those patients, if you push the catheter too much, patient always complain pain and hard to ablate. So in this area, you need to rotate your fluoroscopy to aerial view and comparing the angiogram you took before and where is the PB ostium area. Because the musculature of inferior pulmonary vein, both sides, the inferior pulmonary vein is very shallow. If you give a high power burn, slightly deep side, you have a high risk, high chance of to generate the PB stenosis. So always check the aerial view and confirm where is your catheter tip, comparing the angiogram imaging. This part is easy and safe area, the septal aspects of right side pulmonary vein. But if you generate a transseptal puncture to posterior to high side, sometimes it is difficult to ablate this area because the transseptal hole is here. It's hard to make a good contact. So in this point, you need to rotate your catheter and sheath clockwise altogether. And please make sure your sheath is inside of the transseptal side. Sometimes sheath is outside of left atrium, only catheter is inside. In that case, even though you rotate the sheath vigorously, you can make a good contact. Catheter tip move away from the endocardial surface. This is the easiest part, and this is also important part. Carina, anterior and posterior carina of a right side pulmonary vein is important point. You need to give enough burn. Root part of right side pulmonary vein is also difficult, one of the difficult parts during PV isolation. And I usually try to push the catheter highest point and ablate more, but make sure your catheter tip location is proper or not. Because catheter is straight forward the roof of endocardial surface, and the temperature tip is a little away from the catheter tip, and sometimes it's high risk of tamponade in this area. So don't push too much in this position. It's very dangerous. Okay, so this sphere suggests the impedance dropping and the location of ablation site. It is quite useful for the safety. I don't trust the color change 100%, but at least if the color change to chocolate color, that means that there's some lesion formation, and if you give more energy, it has a risk of complication. And actual the rooftop is here. This area is rooftop of right side pulmonary vein. So I push the catheter inside the pulmonary vein, curve down, and rotate sheath, make this second curve, S curve, and push the sheath gently and make a good contact and fill up the roof side. Even though in this point, the patient respirates vigorously, catheter stability may change, but take your time and give RF energy, sophisticated technique, and fill up all the gaps, and finally successfully generated right side antrum ablation. And the same way to the left side antrum ablation, I give a carina ablation with 30 watt, and watching the signal, ablation signal inside. If there is no signal, I move fast. If there is signal, I give a little more energy to confirm the antral ablation was successful or not.
This is finish up of pulmonary vein isolation. We conducted pulmonary vein isolation with high power short duration ablation successfully and smoothly, and it took about 30 minutes. It's quite fast and efficient ablation procedure. After PVA isolation, please make sure your pulmonary vein is completely isolated by using ring catheter or HD grid catheter one by one. But generally, the guidelines recommend over 30-minute wait because there's some acute reconnection. And some people use adenosine injection to make sure there's complete isolation. But I do not use adenosine nowadays in my lab. And also, during the waiting period, I try to conduct isoprotein provocation and to check the extrapulmonary vein triggers. It takes about 30 minutes, and then lastly we can recheck the pulmonary vein potential. If there's the reconnected pulmonary vein potential, we need to give more energy.
After PV isolation, I exchange it. I use just single transseptal puncture, and I exchange the ablation catheter with ring catheter or HD grid catheter and check the pulmonary vein potential. If it is well isolated, I generated voltage map for the potential, the window ablation cases. I always try to compare the substrate at the time of window ablation, and also the research purpose. And some people, they finish up the case in this situation, but I always try to confirm whether there is XPV trigger or not by isopreteral provocation. It is hard to differentiate the remaining far-field appendage potential inside the pulmonary vein. Then I measure the interval between distal CS spacing, this is spacing, and change the position of a ring catheter to appendage. I compare the distance between pacing artifact to the signal. If it is same in the appendage signal and the PV far-field signal, it's okay. Sometimes we see the SVC far-field potential. We differentiate by SVC pacing. So we confirmed every 4 pulmonary veins are isolated successfully without any touch of ablation. And I would like to emphasize the importance of isoprotein provocation because over 10% of AF trigger comes outside of pulmonary vein. So isoprotein provocation and waiting the basic heart rate over 120 beats per minute and try to induce atrial fibrillation or atrial tachycardia by rapid pacing shorter than 120 milliseconds, maintaining atrial fibrillation 2 or 3 minutes and give internal shock, and we wait over 10 minutes waiting there's another immediate recurrence of atrial fibrillation or frequent PVC. If there is mappable trigger, extra PV trigger, we try to ablate them all as much as possible. And before finishing the procedure, I would like to recommend to check the cardiac silhouette. If the patient have a cardiac tamponade or hemopericardium after going back to the general ward, it can make a disaster. So please check the cardiac silhouette before finishing your procedure. I hope you all enjoyed this video clip for the AF catheter ablation. Because of the development and improvement of catheter technology and mapping technology, AF procedure is easier and easier and shorter, but the number of patients increase. But please make sure AF catheter ablation is not completely safe procedure at all.
sometimes you can make a big mistake and make patient into the risk condition. So please make sure and ensure your technology is perfect, and try to imagine what is your limitation, what is the potential improvement point. So please try to manage it and support patient, human being himself, not a heart arrhythmia or EKG. Thank you.